at the imaging diagnosis of breast cancer. The breast, patients are usually worried whether it's a benign or malignant tumor. These days we have to be cautious about using the word positive because sometimes it means something negative when you talk about COVID, the coronavirus positivity. Today, we would like to look at the different types of cancers, so non-invasive breast carcinoma and invasive breast carcinoma. These are the malignant breast lesions. And today, when you want to screen for breast cancer, you would resort to different modalities such as mammography. And today, I would like to focus on where you need to focus on when screening, resorting to screening mammograms. And for breast ultrasound, I would like to talk to you about why we need to conduct a breast ultrasound before diagnosis and after diagnosis. So probably these are the things that you are most interested in, and we resort to breast MRIs a lot, but this is not going to be the focus of my talk today. Today I would like to focus on mammography and breast ultrasound. Mammography, I think most of you have gone through a lot of mammograms. We take 4 standard views, 2 mediolateral and 2 craniocaudal. So when you are under 40 years of age, we take 2 MLO views to limit to radiation exposure. So these are the MLO view or the CC view, the mediolateral oblique view. This is always the right. And so 2 on the right breast and 2 on the left breast. So 2 MLOs and 2 CC views. So why do we need to take these 4 views since it hurts so much? If we look at the MLO view, our breast is on the posterior nipple, on the big muscle, and on top of the muscle we have the breast. So when we take a picture of the breast, we need something that you call the landmark. And the landmark will indicate how accurate the picture is. And in order to interpret an image, the image itself has to be of a good quality in order to do a good reading. And on top of this muscle, we have the breast, and this muscle has to be included in order for the breast to be seen accurately and for the radiologist to see whether there is a lesion in the breast or not. If the image, the shot, as you can see, does not include the whole area, it may exclude some of the lesions present in the breast. So how do you need to take this view? The radiologist, when seeing a patient, this is where you would insert a cassette, and the compressor will come down from the top. And some patients really dread the sound of this compressor because it hurts so much. The compressor will be placed on the breast, and the breast will have to be evenly spread out so that the deepest area and all of the areas of the breast, including the muscle, will be shown on the image. But since you have to press very well, the more you press the breast, the more the patient will feel this sensation of discomfort. And from the posterior nipple line, this is the standard view, and this is the volume of the breast. So the volume of the breast has to be somewhat matched. So the cassette will have to be placed here, and the compressor will have to come down from the top. And what I say to our radiologists is to firm the position of the patient so that she does not move backwards. We know that the compressor, when it comes down, it will hurt the patient, and the patient would spontaneously like to walk back. But you will have to encourage the patient to stay still to take a good image. Because if the patient steps back, this length of this image will be shorter, and the lesions included in the part that you cannot see on the image will not be included in the image. So you have to encourage the patient to stay still. So these are the different mistakes on mammography images. From the CC view, in some instances, the nipple is not in profile, or the nipple is pointing in a different or in a wrong position, so that the posterior part of the breast will not be included. In the MLO view, you will have to see whether the pectoralis is included, because if the pectoralis margin is not in profile, you will have difficulties in reading the image. So if a patient comes to the hospital with a palpable mass in the left breast, in the mammography, we cannot see a palpable mass because the left breast does not include the areas that need to be seen. So we asked a radiologist to take another mammogram, and we were able to find this lesion. In some instances, through a routine workout, in some instances, in some instances, you might miss these areas where the lesion is present. So it is very important to conduct a right mammogram. So these areas, the deep portion, and the lower part of the breast had a lesion included in this image, as you can see. And we can see a lump here. But for inexperienced doctors, since this is a very small lump of 3 millimeters, so sometimes you might miss this. If this was very visible on both sides of the view, it's very hard for you to miss this. Because here, this lump did not include the deeper part of the breast on the image. So we talked about the importance of length. So if the posterior nipple line is bigger than 1 centimeter, in some instances, the image will not include the areas that need to be included. So the position itself, since the compressor is coming down from the top, people tend to draw back a little. And in the CC view, compared to the MLO view, the breast tissue is less included. It's a little shorter, but so this margin is probably 1 centimeter. So if the difference is 1 centimeter, so you might expect that the whole breast tissue would be seen. But if it's bigger than 1 centimeter, you might miss an important portion of the breast. So this is the right-hand side and the upper side of the breast, and we can see that there is a small lump. And no matter how small this lump is, if you take a right mammogram, you will not miss such lumps. So we need to secure a high-quality mammogram. And in order to do that, we have to have a high-quality equipment, of course. And we also need the participation and the willingness to participate from the patients. So you have to encourage the patient to cooperate with the radiologist to come up with a high-quality mammography. And that is the first step of imaging diagnosis for patients. And while conducting these tests, we sometimes tell the patient that we need another image, we need to take another mammogram, and frequent in our day-to-day practice, and this is a calcification. In the CC view, this is not seen, but we can see this is the MLO view. And some instances, the patients will say, "Oh, I'm fed up. I prefer an ultrasound." But these calcifications are rarely seen in ultrasound, and even if they are visible, it's very difficult for us to really see where they are located. In terms of diagnosis and in terms of timing, it's very important to see that the mammary gland is not seen in this image, so we need to magnify this image and secure an exaggerated CC view, as you can see here on the right-hand side of the slide, so that on the outer upper part, we see that there is a calcification on the breast. So we will take a closer look, and we can do a biopsy using ultrasound instead of going through a surgery. So mammograms need to show both sides so that we can localize and locate where the lesion or the calcification is. So this is another patient who came with a palpable mass, and we can see that there are markers on this image. But even using markers, the lesion was not present in this image. The reason being the lesion was too deep. It was located very deep here, and in this case, we needed to secure a valley view so that both breasts can be seen on the same image. As you can see here, that the breast cancer was present in this very deep area, where we need to take a valley view. So in some instances, even if you even if there is a palpable mass, sometimes it's very difficult to see them on such images, and so you need to know which views you need to secure to see and to locate that mass. And DCIS is ductal carcinoma in situ, and this is an early stage breast cancer, and diagnosing this is one of the biggest objectives of screening, breast cancer screening. And microcalcification is one of the presenting mammographic findings of DCIS. It takes up so in DCIS, 84% would be accompanied by microcalcification. So patients are very worried that they heard that they have microcalcification in tears. So sometimes we have to explain to them. We have to divide these microcalcifications according to morphology and distribution. So there are typically benign types of microcalcification, as you can see here, when it's on the skin or in the blood vessels, or in the fibrosis or the limb length, or this looks bad, but this is after a surgery or when there has been a major biopsy. This is a dystrophic calcification, and in 100 cases, they are benign, so you don't have to worry at all about these findings. But in some instances, we would come across suspicious morphologies. Heterogeneous, there are many words that we use to describe this. In 10% or more, in the case of fine linear, in 70% or more, this would be suggestive of cancer, so you will have to go through a biopsy or a surgery. So calcifications are not always bad, but if you have a suspicious calcification, you will have to do a biopsy. So a patient comes for a workout, and we see that there is calcification, but this was not shown in the ultrasound. So we wanted to see if this person had only microcalcification, and we were able to see that we had a carcinoma in situ, a DCIS in situ, in probably 1/3 of the breast. So you will have to go throughout to come up with a result. And in the case of invasive carcinoma, the primary signs are mass, and undeniable, has mass or masses, and also accompanied by several instances by calcification. So this looks like a atypical calcification compared to the calcification that we saw earlier. So this would be suggestive of an invasive carcinoma. And in the invasive carcinoma category, the secondary signs usually are associated with skin thickening, skin retraction, nipple retraction, and sometimes the axillary lymph node metastasis would be accompanied by a lymph node enlargement. In the breast ultrasound, if we look at the abdominal ultrasound, you would do a CT, you would do an MRI subsequently, according to the different diagnostic steps that will be involved in. But if you do a mammogram and a breast ultrasound, that would be the key to problem solving. So that's where you have to make a decision whether you're going to go on towards a biopsy or to a surgery. So this is a problem solving step. So this is real-time, easy access, and it's not really painful. So why do we conduct an ultrasound? When there is a symptom and when there is a procedure, it would be used as a guidance of interventional procedures. And in breast cancer patients, we would use an ultrasound to conduct a post-operative follow-up. Always a mammography would be conducted first. In the case of dense breast or in the case of a young woman, sometimes you can do away with mammography, but usually you would do a mammography first. And after that, lesion localization and characterization of palpable abnormalities and real-time imaging guidance during biopsy will be conducted subsequently. So this is somewhat uncertain. So we take two steps. So we magnify the image, or if we conduct an ultrasound, we will be able to identify this mass more accurately. In the case of this 37-year-old female, dense breast, we used markers, but it's very difficult to identify what it is. But if you take an ultrasound, the mass is very visible. And in the nipple, sometimes there are patients who have a nipple discharge, and you can see that there is a mass here. Now, if you take an ultrasound, in the ultrasound, not only the mass, but also the mammary gland, as you can see that it has been enlarged. It is enlarged, and sometimes you can be suspicious of nipple-related cancer and conduct a biopsy subsequently. In some instances, the patients might experience breast pain and edema in young patients. Sometimes it's a simple infection, but sometimes we can see a thickening of the skin and an enlarged and inflammation. And in such cases, you will have to do an ultrasound. You can see that the lymph nodes are enlarged, and this can be suggestive of an inflammatory breast disease. So you will have to, in this case, you will not only need to do a mammogram, but also an ultrasound. So you cannot say that ultrasound is better than a mammogram, because if you look at this patient, she had a palpable mass on the left breast, and we did a biopsy, and it was a fibrosis. But if you look at the mammogram of this patient, and if we magnify this, we can see that there is a calcification on the contralateral breast. We did a biopsy, and we found a DCIS. So in some instances, some patients say that I just want to do an ultrasound and not a mammogram because it hurts so much. And I did this 2 years back, and they told me that I had a dense breast. So in some instances, the patients want just a ultrasound. But in some instances, like this case, this small microcalcifications is not seen on ultrasound. So in order to find more or characterize this better, we need both. So the guidance of interventional procedures, usually the breast biopsy most effective when performed under imaging guidance. And accuracy of breast biopsy depends on core specimen number, usually 304, and the needle size. The biopsy method that is most effective and with less harm to the patient. We looked at the different cases where all of these patients had underwent a biopsy, and this patient, every 2 years since 2004, went through a screening follow-up. And in the screening workup, there was nothing. But 4 years down the road, we see that there is a 4 millimeter mass, and we did a biopsy, and we were able to find a low-grade DCIS. So continuously, if we do a follow-up, these small cancers or these small masses can be found. And lastly, the post-op follow-up in breast cancer. Rather than a mammography, the ultrasound has better sensitivity, and the evaluation of the axilla and the supraclavicular fossa, you can opt for ultrasound. And this patient showed this mass in the mammogram and also in the MRI. So we followed up on a regular basis. And more recently, we can see that a small mass was found using an ultrasound. So if you do a regular follow-up using ultrasound, these calcifications or the small breast lesions can be found. And on the right, with a right breast mastectomy, a follow-up was conducted. And in some instances, the mass would grow suddenly. So we need to conduct all of these different modalities according to how your radiologists instructs you will have to resort to mammography, breast ultrasound, and breast MRI. One thing that's important is a close cooperation between the radiologist, between the patient and the technician, and that's for the breast ultrasound. It's an accurate characterization in mammographic or clinical detected breast mass, and post-op follow-up in breast cancer patients. Thank you.